This is Dr. White T. Coleman dictating on our final installment of the Basic Cataract series. This is video 7 of 7, and this is wound closure. Please watch the other 6 videos if you haven't already. Like the other videos, for most of this, we're going to talk about general concepts, not necessarily what is happening on the screen in front of you in real time. For the last couple of cases, I'm going to go over them in real time as they're happening. But until then, we're going to talk about some general concepts, and I'll hit on some high points as they happen. One of them that we're going to look at is an episode of iris prolapse and how we handle that. Another one is a persistently leaky wound that we're going to use tetracaine on a Weck-Cel to seal prior to putting a stitch and being able to avoid a stitch. So the general overview here at the last step of the case, this from a timeline standpoint takes me about 50 to 55 seconds. That's the average. That's been one really interesting point of doing this video series where we take 10 cases and break them apart, is we know what the average time is for each step. So this is 50 to 55 seconds. You can see that 10 cases here are a total time in the video of 9:42. So the first portion I want to talk about is hydration of the main wound and hydration of the paracentesis. And the way I think about it is that I want to divide the total distance of the wound in half. And let's say that a main incision is 3 millimeters long. I'm going to imagine the midway point between the inner and outer portion of the wound, the portion where we're entering the corneal epithelium to the portion we're exiting the corneal endothelium. Let's imagine it's 3 millimeters. And I want to take my BSS cannula and I want to insert it almost perpendicular to the direction of the wound, as close to perpendicular as possible, and halfway between the inner and outer portion of the wound. So if it's 3 millimeters long, we want to be at about 1.5 millimeters inside the corneal stroma, and that's an optimal place in my view to hydrate. The reason for that is that we don't want to be too close to the exterior because we can hydrodissect away epithelium, and we don't want to be too close to the interior because we can hydrodissect away endothelium. And Fuchs patients are especially prone to that. So we want to be careful. You can do diffuse hydration of the main wound by taking your BSS cannula, pointing it superior, and gently hydrating diffusely in the middle of the wound. And that works great sometimes, but I think that you always have to keep in mind the risk of doing an endothelial dissection in that case. And be careful. It should be lower flow than the edge hydration. Another trick that I've learned over the years is that if a main incision is persistently leaky, sometimes that's because the inner leaflet of the wound is rolling and prolapsing under. Especially on a triangular shaped wound, the inner leaflet will just fold out. So basically it's hanging and blocking the wound from completely sealing. It's creating a passageway for a leak, and what you can do is lower the eye pressure. You can burp the main wound, lower the pressure to near zero, and then irrigate back through the main wound, and that flow will take that inner leaflet and lay it back down in a normal position. And a lot of times if you have a persistently leaky wound, that will seal it, especially if you end up with a triangular shape to it and less of a square shape because of the shape of the blade. You'll notice those are a little bit more prone to it. As far as paracentesis hydration goes, one point I'd like to make is that I have my techs keep the eye tip hooked up until I've started hydration in both wounds, because many times there'll be a small nuclear fragment that needs to be removed with IA, and it's a time penalty to have to hook it back up, and that recurs in a minority of cases. But if it does occur, it's nice to already have it hooked up. So I believe this case is the floppy iris case where we're going to have some prolapse. Remember, prolapse is due to flow. This is a case where basically I overpressurize the eye, and that causes the iris to then prolapse through the main wound. You can see as we hydrate the paracentesis, there's an overpressurization of the eye that causes the previously well-sealed main wound to burp. And this is really an annoying time to have an iris prolapse when you've made it through the whole case without it. Now, it's flow that causes prolapse always. So here we lowered the pressure. We irrigated back through the main wound, and we got the iris back inside the eye. It actually wasn't as stubborn as some of them can be. But now we want to be really careful going forward to not overpressurize the eye where it must burp and have the iris prolapse recur. Because once you start an iris prolapse, it is really hard to stop. They're very persistent at coming back out the same wound over and over and over again. Now you can see as a result of the prolapse, the main wound did not seal well. And we're going to use the tetracaine on a Weck-Cell technique. This was taught to us by Uday Devgan when he was on our OR many years ago. He showed us that you can soak a Weck-Cell with tetracaine, and you really want to soak it to the point where it's dripping out. So take the tetracaine from the bottle, put it on the Weck-Cell until it's dripping out everywhere. And you want to hold it on the wound that is persistently leaky for about 1 minute. This has saved me many corneal sutures. And if you hold it on the wound for about a minute, the theory is that the relatively hypotonic tetracaine will flow into the relatively hypotonic corneal stroma in a diffuse way and hydrate in a way that you cannot do with BSS on a cannula. So the rule generally holds true, and we can see in this video that after multiple rounds of hydration, I've still got a little bit of leak in the wound. So here's a Weck-Cell soaked in tetracaine. You can warn the patient it may burn a little bit. And you hold it there for about a minute, and probably 80 or 90% of the time, when you thought you were going to have to place a stitch, this will do the trick. Now, if it's still persistently leaky after that, I think that the rule holds true that if you think about putting a stitch, go ahead and do it. Don't hesitate. I think that's good from several points of view. Number one, it gives you definitive closure, and you're not having to deal with it the next day. You know, the easiest time to place a stitch is when you're in the OR. Also, residents and fellows now with clear corneal incisions, we put so few stitches in, I think you get insufficient experience sewing a lot of times. When our fellows first start in our fellowship, we have them place 40 simple interrupted sutures in a model eye, just so that's second nature if it has to be done. Now we can see in that case that the tetracaine trick worked. The wound was tightly sealed, and we avoided a stitch even after the iris prolapse. So I'm going to talk to these last cases as they go. So we're 50% of the way between the inner and outer portion of the wounds, almost perpendicular, hydrating 1/2 of the paracentesis. And in general, I'm trying to overpressurize the eye slightly. I want the pressure slightly higher than I'm ultimately going to want it to end up, and I'm going to set the pressure when I place antibiotic. The antibiotic I'm using is ceftriaxone, 0.1 milligrams, 1 milligram per 0.1 cc's of BSS. If they have a cephalosporin allergy, we're using Vigamox. The way you mix that is the whole bottle of Vigamox, 3 mLs, with 7 mLs of BSS, and then you inject 0.3 mLs into the eye, a little bit more volume in that case because the concentration is less, or minimum inhibitory concentration is less. This time, I'm hydrating both sides of the paracentesis. I thought it was still leaking a little bit. You want to be careful not to overpressurize the eye and get iris prolapse like I did in the other case. And we don't really have to push hard on the wounds. We don't want to burp them when we're checking them for leaks. We want to just barely touch them, just to dry it up enough so you can see if there's active flow. When the eye pressure is too high, if the wounds are oozing just a small amount and there's not real direct continuous flow, that's okay. That still can be a sealed wound, because when the eye pressure gets back to normal, when you set the pressure as the antibiotic goes in, the wound will completely seal at that point. So you'll see several examples here. In that case, I was burping a little more viscoelastic out. But you'll see several examples in this case series where it's oozing a little bit with the pressure higher than physiologic, higher than you want it. And I don't go back and hydrate anymore. All I do is put antibiotic in, burp the paracentesis slightly, and the wound is completely sealed. This is the last one, same principle, perpendicular, 50% of the way between the inner and outer leaflet. Hydrate half the paracentesis. A little burp in the main wound to take the inner leaflet of the main incision and fold it back in the eye in a normal position to make it seal. You can see this eye is well sealed. The lens is well centered. And this concludes our Cataract Basics series. Thanks so much for watching. Please like our channel and subscribe. There'll be more supplemental videos to come.